Do you have your statement or whatever? Okay. Good afternoon. I'd like to call this hybrid joint hearing, roundtable to order. Today is Monday, March 31st, 2025. The time is 1:04 p.m. I'm at-large Councilmember Christina Henderson, Chair of the Committee on Health. We're hosting this joint roundtable with the Committee on Judiciary and Public Safety to consider PR 25-108, the sense of the Council on supporting humane and trauma-informed responses to behavioral health crisis resolution of 2025. PR 25-108 calls for a more coordinated and effective and compassionate response to behavioral health crises in the district. Despite the availability of alternative crisis response services, most individuals experiencing a behavioral health crisis in the district still call 911 or seek care in a hospital emergency department, where they frequently encounter prolonged wait times for treatment or admission. Historically, when individuals call 911, the Office of Unified Communications, OUC, has dispatched the Metropolitan Police Department to respond. However, since 2020, the district has worked to divert appropriate behavioral health crisis calls to the Department of Behavioral Health instead. The Substance Abuse and Mental Health Services Administration, SAMHSA, recommends a crisis response system that ensures three key elements. One, someone to talk to, a 24-hour crisis line that provides immediate emotional support and guidance. Two, someone to respond, trained professionals, including mobile crisis teams who can provide in-person intervention. And three, a place to go, crisis stabilization options that serve as alternatives to an emergency room and to jail. The sense of the council resolution urges the mayor to take the following steps to strengthen the district's response system. Enhance the crisis call operations to ensure that at least 90% of diverted calls from OUC are answered within 15 to 20 seconds by 2027, reducing MPD's involvement when there's no imminent safety threat. Implement a warm handoff policy for 988 and the Access Helpline, which requiring call center staff to stay on the line until a provider is reached, and ensuring follow-up occurs within 48 hours when needed. Improve OUC call taker training to better identify behavioral health crises and ensure that MPD is dispatched only when necessary due to imminent risk of harm, Expand and properly resource mobile crisis teams, ensuring that DBH's community response team and the child and adolescent mobile psychiatric service, also known as CHAMPS, can respond to high priority calls within 5 to 9 minutes and efficiently manage lower priority calls. Invest in crisis stabilization options, including community-based crisis beds, short-term observation units, and respite centers. And finally, empower individuals with behavioral health disabilities to have a say in their crisis care by allowing them to specify their preferred response. I will now turn to my co-chair, Ward 2 Councilmember Brooke Pinto, who is the chair of the Committee on Judiciary and Public Safety, for her opening remarks. Councilmember Pinto.
Thank you very much, Chairwoman Henderson, for introducing this resolution and for co-hosting this joint hearing with us today. I'm looking forward to the testimony and the discussion on this really important issue on how we respond when there is a behavioral health crisis in the city. As chairwoman of the Committee on Judiciary and Public Safety, I understand that our OUC 911 call center and MPD play an important role in responding to many of these calls. When there is a behavioral health crisis, there must be resources for residents to have someone to talk to, for there to be someone to respond, and for there to be a place to go for those in crisis and in need. I know we can be doing this better. We also must understand the logistical challenges that there may be in providing those responses. And I'm looking forward to the discussion today as we continue the conversation, especially around building up the staff capacity to do this work. As part of the Secure DC Omnibus that the council passed last year, we established a pre-arrest diversion task force to look into other ways that the city can be proactive and supportive to people who may be experiencing crises that are related to public safety. And that work is going on from the Criminal Justice Coordinating Council effort. A health-first approach to handling behavioral and mental health challenges ensures that individuals are connected to the appropriate services like counseling, residential psychiatric support, substance use treatment, and housing support. And I again want to thank all of the public witnesses who are here today to share their experience, whether that's lived experience or in their professional capacity. We really appreciate all of your perspective and being here today to discuss this important issue. Thank you.
Great, thank you. We'll now hear from our public witnesses. Witnesses representing organizations limited to one per organization will have 5 minutes to testify, and those testifying as individuals will have 3 minutes to testify. You are certainly welcome to submit longer written testimony for the record. So we ask that folks be conscientious of their time. I'll give you a nudge when your time has expired. It's not because we don't find what you're saying is important, but we want to make sure that everyone has an opportunity to speak today. All right, so we're going to start with our in-person witnesses first. We have 4 seats. Rachel White from DC Action. Oh, I don't see Rachel. Okay, Kristen Ewing from DC Appleseed. Chris Gamble from the Children's Law Center. Tahir Duckett. Okay, from Georgetown Law Center for Innovations and Community Safety. And then Jillian Buford. Okay, great. All right, Kristen, when you're ready.
Good afternoon, Chairpersons Pinto and Henderson and staff. My name is Kristen Ewing, and I am Policy Counsel for DC Appleseed. When behavioral health providers respond to crises, several positive things occur. First, focusing on de-escalation and professional treatment rather than enforcement leads to better health outcomes. It can also reduce the likelihood of unnecessary arrest or harm. This is crucial since those with untreated mental illness can be up to 16 times more likely to be killed during a police encounter. Although we support all first responders receiving robust crisis intervention and de-escalation training, this isn't a substitute for professional behavioral health services. Second, responding with behavioral health professionals fosters a more supportive environment, helping individuals feel safe and understood during vulnerable moments. While many jurisdictions, including DC, have co-responder programs for behavioral health crises, the district should continue to enhance and grow crisis response teams that can react without police, as evidence shows this is a more effective model with strong public support, even over hiring more police. Last, involving behavioral health professionals can alleviate the strain on emergency services and law enforcement, allowing them to focus on situations that require their specific skills. This can also potentially reduce costs by lowering hospitalization and incarceration rates, as well as reducing the use of law enforcement resources. The district's investment in behavioral health resources and crisis response is disproportionately low compared to its investment in police and medical responses. Currently, MPD has over 4,000 sworn officers and staff, and FEMS has 1,600 firefighter EMTs and 300 paramedics. However, the community response team has 44 FTEs with 19 vacancies and an average response time of 52 minutes. CHAMPS has fewer staff, operates only Monday through Friday from 8 a.m. to 8 p.m., and has an average response time of 76 minutes. To swiftly and adequately meet the needs of all district residents in crisis, DC must expand overall FTEs, raise grants and salaries to a competitive level, and invest in a workforce pipeline. This will ensure proper staffing, retention, and recruitment for these vital positions. The DC Stabilization Center plays a critical role for adults facing a substance use crisis in the district. However, to truly make stabilization centers meet the needs of the community, we must expand stabilization center services to also meet the needs of residents experiencing mental health crises, increase the number of stabilization centers throughout the district to ensure care and access for residents in all wards, create a youth stabilization center, and explore the addition of safe consumption sites to the district stabilization centers. Oversight of existing psychiatric facilities is also vital to ensuring high-quality care and outcomes. The district must ensure that all existing behavioral health facilities are adequately staffed and provide high-quality, trauma-informed care. When these facilities provide neglectful or inadequate care, something that several facilities in the district have currently been facing, they not only do a disservice to the patients, but also create a chilling effect on utilization. We also need to ensure that the district has ample alternatives to hospitalization. We need sufficient facilities and programs for adults in need and to develop similar options for youth. Currently, DC has no partial hospitalization program provider for youth and lacks a local psychiatric residential treatment facility. Last, we need to improve awareness of 988 and other behavioral health resources such as the Access Helpline and CPEP and stabilization centers. The information for these resources should be readily available in all public spaces, including schools, libraries, public transportation, and community centers, hospitals, medical facilities. Ideally, 988 will become as ubiquitous as 911, but DC has not effectively launched an education campaign for this crucial service. For instance, 988 is not even mentioned on the DBH or OUC homepages. If DC is going to properly invest in behavioral health crisis response, this must include ensuring the public is aware of all of their care options. Thank you for this opportunity. I have submitted a more detailed written testimony, and I'm happy to answer questions.
Thank you. Mr. Campbell.
Good afternoon, Chairperson Henderson, Chairperson Pinto, and members of the Committee on Health and Committee on the Judiciary and Public Safety. My name is Chris Gamble, and I'm a Behavioral Health Policy Analyst at Children's Law Center. I'm also a licensed professional counselor who has worked with and responded to children experiencing behavioral health crises. Children's Law Center represents over half the kids in DC's foster care system. These youth are at risk of experiencing behavioral health crises due to the trauma they've experienced through either abuse or neglect or even through home removal. As we have testified before, ineffective crisis response at times affects foster parents' willingness to be a placement for a youth, thus destabilizing the youth's living situation and further destabilizing their behavioral health. We support the Council's resolution and agree that DC needs a more coordinated and effective crisis response system, particularly in terms of meeting the needs of children with appropriately trained behavioral health professionals. We're now about 2 years into CHAMPS having their hours reduced to 8 a.m. to 8 p.m. on weekdays, with the community response team previously only dedicated to adult crisis response covering all other times. In FY24, for the 77 times that the CRT was deployed to respond to a child in crisis, 62% of those deployments resulted in an involuntary hospitalization. Altogether, while a direct cause is uncertain, there has been an increase in the number of both CHAMPS and CRT deployments, resulting in involuntary hospitalizations, known as FD12s, of children from 50 in FY23 to 124 in FY24. In addition to the rise in FD12s of children, conflicting information has been given regarding the protocol for transportation in these situations. DBH's most recent performance oversight responses identify FEMS as the transportation provider, but DBH then stated verbally in the government witness hearing that MPD provides transportation. Clarifying this protocol is made even more urgent by MPD's potentially traumatizing policies that require minors to be handcuffed when transported in an MPD vehicle for an FD12. Our crisis response system currently does not provide the clarity that's needed to know who's going to respond and what the process of getting help is going to look like when a child is in need. And I'll end today by sharing the experience of a Children's Law Center client, demonstrating what the current web of crisis response options can result in. This young child experienced a behavioral health crisis before heading to school one morning. The child's caregivers, concerned for their own safety, contacted the CRT for help since it was before 8 a.m. during the week. But rather than go to the scene themselves, the CRT left a message for CHAMPS to call the caregivers back when available, and then tried to request a crisis intervention officer from MPD, but there were no crisis intervention officers available at the time. Ultimately, FEMS ended up being the only on-scene presence, and they were able to get the child to voluntarily go to the hospital in their ambulance. Once at the hospital, because the child did not present an immediate danger in that moment, they were quickly discharged. So 4 teams were in some way involved in this scenario, but no behavioral health professional was ever on the scene, which does not align with national guidelines for best practice. Intentional planning and investment are needed for our crisis response system to operate according to these standards. Thank you for the opportunity to testify, and I welcome any questions you may have.
Thank you. Mr. Duckett. Got to turn your mic on, Mr. Duckett. Just hit the button. There you go.
Thank you. Out of practice. Good afternoon, Chairperson Henderson and Chairperson Pinto, and thank you for convening this roundtable. My name is Tahir Duckett. I'm the Executive Director of Georgetown Law's Center for Innovations in Community Safety. We work with jurisdictions to develop a more modern community safety infrastructure. For the past several years, we have partnered with alternative behavioral response programs from across the country on research, policy development, technical assistance, and convenings. One of our projects, the Alternative Response Research Collective, brings together a diverse group of 9 leading programs across the country that are working together on building best practices and sharing expertise across jurisdictions. We've been lucky enough to see several of the most successful behavioral crisis response programs in the nation up close. Programs like Albuquerque Community Safety, a department that serves as the third prong of Albuquerque's first responder system alongside police and fire, and responds to over 3,000 calls every month. Or Durham's HEART program, which operates within the city's community safety department and responds to over 1,000 calls every month. These programs are delivering incredible outcomes for their communities, providing higher quality, more tailored responses to people in need, delivering better connections to services, and reducing unnecessary criminal legal system involvement, including by reducing the burden on law enforcement. I must emphasize that last part. In most of these cities, the biggest cheerleaders of these programs are law enforcement officers. Most officers didn't sign up to arrest somebody for stealing some shut-eye in a Starbucks bathroom. Most officers don't want to be spending so much of their time on these calls. They'd rather spend their time on preventing and responding to serious crime. Unfortunately, the district's behavioral crisis response program lags far, far behind the programs that we're partnering with across the nation, whether they are larger jurisdictions like Atlanta or San Francisco, or smaller jurisdictions like Evanston, Illinois, or Rochester, New York. It is not just a question of budget or staff. For example, Durham's HEART program operates with 50 staff, among them 21 clinicians, 10 peer responders, and 7 EMTs, and on an annual budget of $6,000. They're directly dispatched from 911 and on average arrive on the scene 6 minutes after dispatch. Durham isn't alone. I can go down a long list of programs that are showing real promise at reducing our over-reliance on police. The most successful tend to share a few things in common. One is direct dispatch of responders from 911. People have been socialized since childhood to call 911 when we need the government's help. And when we add additional layers between 911 dispatch and first responders, we tend to see slower response times and additional opportunities for errors. The second is a broad range of call types. Some programs have only prioritized lower acuity calls, usually out of an overabundance of caution. Others, especially those that have grown out of the mobile crisis team tradition, only respond to higher acuity calls. It needs to be both. That's how you start to make a meaningful dent in lowering the burden on MPD and ensuring that residents get connections to care before they end up in crisis. And then third is competitive pay. Because law enforcement is such an extremely expensive resource, jurisdictions are finding that well-paid responders are still less expensive to deploy than law enforcement. But underlying each of these is a real political commitment from the executive to make these programs work and a shared vision from political and programmatic leadership that these are truly first response programs. That's a real pivot from a few years ago when most political leaders thought of first response as encompassing only police, fire, and EMS. It's also a pivot for many clinicians who didn't get their licenses expecting to provide services at 1 a.m. on a Friday. But without that expanded vision, we don't see these programs realize their true potential, which is to divert a really significant chunk of 911 calls away from police. Take Durham, for example, again. HEART's unarmed community response teams are directly dispatched from 911 and respond in person to a broader, more aggressive set of both lower acuity and higher acuity calls than DBH's CRT teams take. The key is that they are still calls where a solo law enforcement response is unnecessary and can at times be counterproductive. I want to close with this. Many of us have long rued that residents' perceptions of crime rates don't necessarily match what we see in the statistics. Even outside of the spike in violent crime in the district in 2022 and 2023, when we have been at all-time lows, perception has remained in the district that crime is high. Social science researchers have found that residents will conflate neighborhood disorder, including mental health crises, substance use disorder, and visible poverty, with crime rates. Some say that's all the more reason to send in police to clean up the streets, but the research also tells us that approach is not only ineffective but counterproductive. It leads to more crises and can deepen the cycle of extreme poverty. Alternative first response is the first step, not the only one, but the first one in reorienting how our city deals with these problems towards the kinds of solutions that will be felt not only by residents who need help in their most vulnerable moments, but also by the rest of the district as they think about the safety of their neighborhoods. Thank you.
Thank you. Jillian?
Good afternoon, Chairman, Chairwoman, Chairperson Henderson, and Chairperson Pinto. Thank you for the opportunity to address you all here today. My name is Jillian Burford, and I'm the policy organizer for Harriet's Wildest Dreams, a community defense hub working to improve material conditions of Black residents across the greater DC area. I'm also a DC native and a second-year MSW student at Howard University School of Social Work with a concentration in community administration and policy. I'm testifying today to stress the importance and urgency of this crucial life-saving resolution. Almost 2 months ago, I testified before the Committee on Health to urge the adoption of the People's Response Act to improve the district's current mental health crisis response system and strengthen DBH's relationships and trust among DC residents. Our current system is flawed and fails to provide our neighbors with no minimal alternatives to engagement with law enforcement in their most vulnerable moments, such as Clifford Brooks, a 41-year-old DC native whose life was tragically cut short during a mental health crisis by an MPD officer on January 24th, 2024. Mr. Brooks's life was not cut short by a rookie cop or someone untrained in crisis response. His life was cut short by a 31-year veteran with crisis intervention training. At the end of the day, a cop is still a cop. Mental health is a matter of public health, and response to crises should be treated as such. Mr. Brooks's story is unfortunately not unique in the least bit, but DC has an opportunity to put an end to that chapter through employing community-centered responses designed to keep us safe. We are urging the district to follow suit behind cities like Denver, Oakland, and Camden, whose leadership heard the people and successfully put the reimagining of public safety in action. Denver's STAR program dispatches mental health professionals to mental health crises as first responders. Oakland's macro initiative diverts police funding towards mental health crisis intervention. Camden prioritized de-escalation and community policing after reforming its police department. Alternatives to policing works if the community is given the opportunity to step in to help. We are urging DC to act now by publicizing and strengthening the 988 crisis line so people know that there's an alternative to 911. Training 911 dispatchers to redirect crisis calls to 988 instead of MPD. Expanding and fully funding crisis response teams and CHAMPs to respond quickly and effectively to crises. Investing in crisis stabilization centers, respite centers, and community-based crisis beds to ensure that people have access to care. The time for trauma-informed, community-centered care is here and now. Accessibility, diversity, equity, livability, opportunity, prosperity, resilience, and safety outline our shared DC values. Together, we can work to build a DC that stands fully within them. The People's Response Act provides that chance. As a burgeoning social worker, I am willing to give all that I can to bring this groundbreaking, life-saving effort into fruition because I know that this is something that we can accomplish together. Thank you for your time, and I'm happy and willing to answer any questions you may have. Thank you.
Thank you so much to this panel of witnesses. We'll do 5 minutes. Okay. We'll do a quick 5-minute round. For 3 of you, I've heard you testify on this particular issue before, and we've been in conversation about, incidents that have occurred in the district and other places where response. I do want to dig a little bit deeper. Mr. Duckett, in your testimony, and even you, Ms. Buford, you talked a little bit about what's happening in other jurisdictions. To your knowledge, have any of these other jurisdictions, like Durham, or I think you said Camden, have they done an evaluation to determine the efficacy of their approach And by that, I mean, even just sort of looking at the pure numbers of the number of calls that were going to their 911 for mental health response versus what happened after they implemented their robust programming.
Yes. There have been a few studies that have been done, several more in process. And in fact, our center is conducting a study that is an analysis that's literally just getting off the ground right now, an analysis of Atlanta's Policing Alternatives and Diversion Program, as well as Albuquerque's Community Safety Department. There's also a recent, there is a very initial study of Denver STAR program that was published several years ago that indicated some preliminary impacts on low-level crime within the jurisdiction that Denver STAR was first being launched as a pilot. I know of several other programs that are in the midst of long-term studies, but because so many of these programs launched in just the last few years or saw significant expansion in the last few years, many of them are in the last stages of like 3, 4-year, 5-year evaluations.
Okay.
While I do not have the information off the top of my head, I will make sure to include it in my written testimony. But as Harriet's Wildest Dreams, we are part of a national campaign to push the People's Response Act. And the campaign was built on perspectives from constituents across the country, as well as looking into the efficacy of these programs, such as Camden's program, Denver's program, as well as, I just drew a blank on the other city that I referenced.
Oakland, Metro.
Thank you, Oakland. So we have been hearing for years that these programs do exist and they have been working and they have been effective. And so what we want DC to do is to take a dive into what these programs look like and what that could look like for DC. I feel like that may not have answered your question directly, but I will make sure to put this in the written testimony to provide more exact data from the study that I referenced from the Movement for Black Lives and Gen Forward's perspectives on community safety from Black America.
Yeah.
That is where the data came from.
I think that I'm sort of thinking of, and I think Mr. Duckett, you're right. All of these cities, not all of them, but many of them sort of moved in the same direction at the same time. So, DC announced our pilot program, I think in 2021. And then, a lot of jurisdictions were trying to look to alternatives for policing around that particular time. Mr. Duckett, in your testimony, you talked about two big things. One, direct dispatch, and then two, the other part being competitive pay. I'm curious, for the jurisdictions that have these programs, are those who are responding to the behavioral health crises, are they classified as first responders?
Some of them, right? And in some jurisdictions, they will tell you that was a real difference, right? That identifying and classifying within statute certain some of the responders as first responders has made a difference in terms of their ability to attract workers. Sometimes first responders are eligible for different kinds of benefits.
Yeah.
Right. And so that can be incredibly helpful. But some of it is also just about orientation, right? Understanding the work as first response, which is just a slightly different way of thinking about the work than, sometimes, like I mentioned before, some clinicians, right, that actually wasn't necessarily what they went to get their MSW in, right? And so there needs to be a sort of understanding that this work is a little bit different. It's kinetic. It's out on the streets. It is, late hours, unusual hours. It should be compensated as such, much in the same way that we've decided to, compensate law enforcement officers for that kind of work.
Okay. Thank you. Councilmember Pinto.
Thank you. Thank you all so much for your testimony. Chris, you talked about the lack of availability sometimes when a crisis intervention specialist is called. Can you speak about kind of the different experiences people will have with traditional law enforcement versus what can be expected when a crisis intervention specialist shows up?
So in terms of, I guess first in terms of the availability, I think it's just natural that MPD is probably going to be available first in terms of getting on-scene response because they have cars with sirens that people have to move out of the way from. They have precincts all over the city so they can just get there faster. That's sort of why they end up being the first response a lot of the times. But in terms of once they're actually on the scene, I mean, the difference is, although even a crisis intervention officer gets, I believe it's like 40 hours of training on behavioral health crisis response, it can't be compared. And, I myself, yes, I'm a counselor. And so it's just tough for me to see any equivalence there. They may be able to speak to the child in like a kinder manner, but that's different from a fully trained behavioral health professional that's been like their whole education and training to assess, to figure out just the full context of what's going on. And really so the national guidelines that I was referring to come from SAMHSA, which we know, who knows what kind of guidelines they're going to be able to give in the future, given the cuts. But it's really the ideal is to handle a crisis so that the child is not having to leave the home. In the example I gave, of course, the child voluntarily chose to go to the hospital, but really we want to be able to de-escalate situations so that there's no need to go to the hospital, and a behavioral health professional is best equipped to do that.
Thank you. Does anyone else have other thoughts on this, on the different type of training and interaction that we could expect with a behavioral health expert versus a police officer?
I just want to add that inevitably, when someone shows up in a police uniform who has a gun on them, there's going to be a heightened level of, anxiety and fear, especially with certain populations who have, a history of poor interactions with police. So even if they were incredibly trained, they're still coming as a police officer with the ability to arrest you, put you in a police car, handcuff you in a way that just isn't there when you have someone who's in plain clothes or, some sort of uniform because they're part of a crisis response team or CHAMPS. So you're already setting the bar for the anxiety and the response, the visceral response higher when someone shows up in a police car, in a police uniform, carrying a weapon.
Thank you. Go ahead.
During my last testimony, I referenced Mr. Brooks's sister. In response to the MPD officer shooting and killing her brother, she asked why DBH was not called to the scene. And the response was because the officer was crisis intervention trained. But at the end of the day, if this is someone who had already been dealing with trauma with losing 2 family members earlier that month, there's not a clear mind. Someone in the midst of a mental health crisis is not going to be able to respond to directives because they're not thinking in the same way that we are thinking right now, because we are not in the midst of a crisis. We're just talking to each other. Justice impacted folks are dealing with a trauma that non-justice impacted folks cannot actually put into words because it's not our lived experiences. And so in witnessing a crisis response in real time is actually what pushed me to become a social worker, so I can do the work necessary to influence policy to avoid situations like that. So we can have resolutions where we are centering community response, where we are thinking about the trauma that impacts people in the midst of crisis. In reality, if we had a place to go for Mr. Brooks, he wouldn't have had to leave his home. He wouldn't have had to leave the neighborhood that he was born and raised in or whatever to be taken to Washington Hospital Center and shot and killed on North Capitol Street because he needed help. So thank you.
Just very briefly, because I agree with everything that my colleagues have said. There is a real tension, or can be a real tension between the ways in which law enforcement officers are trained to control scenes, to prioritize the security of a scene in a way that is can run counter to the best practices of crisis intervention in the moments. And so It's true that, 40 hours of crisis intervention training is, better than nothing. But when you counter that with the weight of a police officer's training and experience, which is really about controlling scenes and ensuring that they have security over scenes, that can just run counter. It's just a slightly different kind of a job. And even the best officers who have, really good skills in de-escalation, those two things are living in tension at the same time.
Thank you. Thank you all very much.
Thank you all. And if you haven't supplied your written testimony, please make sure you, for the record. Thanks. Okay, we're going to go to the next four. Frankie Seaborn, Jasmine Bellard, Bliss Davis, Jediah Thomas, and Lena S. Okay, Frankie, when you're ready. Yep.
All right. Good afternoon, council members Henderson and Pinto, and a special, albeit rare, thank you to all council members who co-signed on this resolution today. My name is Frankie Seabron. I am the program manager for Harriet's Wildest Dreams. We are an abolitionist community defense hub who support all of those at risk of state-sanctioned violence. I'm a third-generation Washingtonian, a mother of 2 children, and a former special education teacher. Harriet's Wildest Dreams team has worked diligently with Councilmember Henderson's office to bring an iteration of the People's Response Campaign to DC. My comrades today will go into detail about other places where crisis response pilots have worked, but it's imperative that we prioritize mental health as a public health issue, not a law enforcement issue. Currently, the city continues to rely on MPD as first responders for behavioral health issues, despite the fact that MPD officers lack the necessary training to provide trauma-informed care, which you've heard in extension from the last panel. By passing the sense of council on supporting humane and trauma-informed responses to Behavioral Health Crisis Resolution of 2025, the council will take a huge step toward prevention and keeping the most vulnerable in our communities safe. Visionary Kwame Ture said, "There is a difference between peace and liberation. You can have injustice and have peace. So peace is not necessarily the answer." And I will remind the council that detention is not prevention. Holding people in jails, the expansion of pretrial detention, and over-reliance on mass incarceration has not changed the outcomes for the most marginalized and vulnerable among us. Being accused of a crime should not be a death sentence, but this is what is risked each and every time someone is held prior to being convicted in this city. We all deserve safety and wellness, and the answer to safety is never going to be a cage. Even still, 2 years later, we cannot incarcerate our way out of mental health crisis and access or lack thereof of resources. That is why we are excited today to be working together towards solutions like this very resolution, which is the first step. After this, I urge the mayor to get very serious about coordination and accountability of the agencies she manages. I trust the council to consider next steps in the process, which include legislation that will more readily advertise 988. It is especially crucial during this time, since we know MPD officers essentially have a license to kill without true accountability measures. We witness not only the pardoning of convicted officers, but the reinstatement of those same officers who killed Karan Hilton Brown, neither of whom were ever held pretrial despite committing a crime of violence. We must by all means reduce our community's exposure to policing. And that is exactly what this resolution calls for. We need those on the scene who are trained to de-escalate, not people who show up with guns. We need trained dispatchers who understand what a mental health crisis looks like, what it sounds like, and are able to direct those calls in a timely manner. Our communities deserve better. This resolution is the first step, but it cannot be the last.
Thank you. Jasmine?
Good afternoon, and thank you for allowing me to testify today. My name is Jasmine Ballard, and I am a licensed social worker at the bachelor level, a former educator, and a former restorative justice coach. I'm here to advocate for a community-centered, trauma-informed mental health crisis response system in Washington, D.C. As a supporter of Harriet's wildest dreams, I believe that community-led crisis response is the key to safety and justice in this city. My training with the Crisis Prevention Institute emphasizes the importance of creating a culture of trust and safety within our schools, organizations, and communities by practicing nonviolent crisis intervention strategies. My training enables me to de-escalate crises by assessing risk behaviors, recognizing stimuli that elicit trauma responses or heightened emotions, and offering clients choices that uphold their dignity and autonomy. I would also like to highlight that behaviors that we see in mental health crises may sometimes be disruptive, but they are not inherently dangerous. Implementing de-escalation tactics by community crisis response programs prove to be effective. For instance, as previous speakers have mentioned, I would like to consider the Mobile Assistance Community Responders of Oakland program, otherwise known as MACRO. MACRO responds to needs ranging from behavioral health issues and wellness checks to community disturbances, aiming to reduce police and fire department responses. Between October 2024 and March of this year, MACRO resolved 97% of incidents through de-escalation practices, providing basic need support and transporting service recipients to another location. Denver, Colorado's Support Team Assisted Response Program, or STAR, responds to any person needing urgent help related to mental health distress, poverty, homelessness, substance use, resource needs, and more. The team can provide medical assessment, triage, crisis intervention, de-escalation, transportation, and resource connection for community members in need. The organization's advisory committee reports that the program's greatest strength is in its partnership with a network of trusted partner organizations that provide culturally competent care to service recipients. MACRO and STAR are not the only organizations of their kind. By expanding and fully funding crisis response teams and CHAMPs, in addition to further publicizing and strengthening the 988 crisis line, DC not only joins the development of community crisis response programs, but can become a leader in it. It is imperative to promote these programs to protect our most vulnerable populations. Although disabled and/or neurodivergent people are a minority of the U.S. population, the Bureau of Justice Statistics provides that this population represents more than 50% of the incarcerated adult prison population. The Department of Education provides that between 30% and 60%, and in some cases up to 85% of the incarcerated youth population have disabilities. The Council has the power to ensure that mental health crises are treated as public health issues and not criminal matters. I thank you sincerely for your time and consideration.
Thank you. Jediah?
Peace, council members. Thank you for allowing me to testify today. My name is Jediah Thomas, and I am a student currently residing in Ward 1. I'm here to advocate for a humane, trauma-informed mental health crisis response system in Washington, D.C. As a supporter of Harriet's wildest dreams, I believe that community-led crisis response is the key to safety and justice in our city. Most of my experiences with police and other law enforcement personnel have been negative, agitational, and escalatory. Much of my family has been harassed by police. Some have been incarcerated, and all have found them ineffective, if not agents of escalating in times of crisis. As such, much of my family and close peers refuse to call 911 or any other law enforcement services in both mental and physical crises. This is testament to a deep historical and generational trauma that plagues my family and many others throughout the country. It is within this context I urge for this resolution's trauma-informed care for culturally and community competent behavioral health professionals, as opposed to agitational armed officers. Our current response to mental health crises in DC is inadequate and, in my opinion, inhumane. Despite the United States government promise of presumption of innocence, my nightlight is red and blue cop lights that circle the LaDroit community every night. My white noise is the frequent sirens that these police officers use to ensure the people residing in the apartments across the street know they are being surveilled. And then we, the people getting surveilled, are expected to ask these same officers for assistance in mental health crises, despite such crises tending to render people in a state of reduced ability to articulate their needs. This is not just a perceived fear. We know that when someone in crisis calls for help, they are more likely to encounter armed law enforcement than trained mental health professionals. We know that the criminalization of mental illness has deadly consequences. Maybe if there was the collective government and community commitment to providing mental health professionals and resources in response to mental health crises, Clifford Brooks would still be here today. Instead, a crisis intervention officer shot and killed him. His story is not unique. Across this country, police interactions with people in crisis lead to tragic outcomes. We do not have to accept this reality. I cannot accept this reality. Cities like Denver, Oakland, and Camden have successfully reimagined public safety with the STAR program, macro initiative, and more. These models prove that alternatives to policing work. Local governments and legal institutions should either support the efforts of community-based organizations like Harriet's Wildest Dreams with the DC Safety Squad, or get out of their way. As a person of African descent who aims to honor the legacy of my ancestors and their struggle and maroonage, I come from the belief that we keep us safe. We always have, and we will continue to do so. Therefore, I argue that any system of government should work in support of this. I know the time's up, but I urge you to support the full implementation of the People's Response Act and commit to a community-centered approach to the crisis response. Thank you for your time. Give thanks.
Thank you. Lena?
Thank you for allowing me to testify today. My name is Lena, and I am a nonprofit researcher, and I study community-driven policing alternatives across the country. I am also a Ward 4 resident and a supporter of Harriet's Wildest Dreams. Based on my scholarship and my personal experience, I strongly support the vision of community-led crisis response laid out in this resolution. This resolution is based on a simple idea. People who are experiencing mental health crises deserve care and dignity, not criminalization. Our current system forces people in crisis into the path of police because there are so few alternative resources to draw on. This leads to horrifying police killings like those of Clifford Brooks and Sonia Massey, as well as devastating criminalization. About 1 in 4 people with mental health disorders have been arrested in their life. When there's a fire, we send the fire department. When someone is having a medical emergency, we send EMTs. When someone is experiencing a mental health emergency, we should send behavioral health specialists who are trained to de-escalate the situation and provide care. People from communities that have been abused and profiled by police often do not want to call 911, but feel that they have no real alternative. This is why we must urgently increase awareness of 988 in DC to give people a real alternative that they have the power to choose. We must also invest in the Department of Behavioral Health's call-taking capacity so that 988 calls can be answered quickly. For mental health calls that do end up with 911, we should also ask callers which responder they prefer, giving them a say in which services they receive. Additionally, we must train 911 call takers and dispatchers to ensure that all eligible mental health related calls that end up with 911 are assigned to mobile crisis teams rather than police. To successfully respond to these calls, we must invest in and expand DC CRT and CHAMPS programs, ensuring that they have the resources to respond to all eligible mental health calls in the district, 24 hours a day, 7 days a week. Finally, we must invest in community-based mental health services such as respite centers to ensure that people have a safe place to seek help after an incident. In the last 5 years, hundreds of non-police crisis programs have been created across the country. Successful programs are currently operating in cities like Denver, New Orleans, Albuquerque, and San Francisco, and many respond to thousands of calls per year. One example of such a program is Durham, North Carolina's HEART program. Launched in 2022, Durham's non-police response team responded to over 8,000 calls last year. Responders report feeling safe on over 99% of calls, and police were only needed for backup in 0.04% of calls. 57% of Durham residents say they now feel more comfortable calling 911 thanks to the program. I also know how urgently these programs are needed on a personal level. I have seen many neighbors in distress and crisis coping with huge setbacks. My neighbors and I do what we can to help each other, but we don't always know what to do or have the time and resources to address every problem. We cannot risk calling 911 and escalating situations to arrest or violence, so we try to muddle through as best we can. A strong community-led crisis response program would give us a third option, one that would have a much better chance of getting people the help they need. Thank you for your time.
Thank you. And thank you to this panel of witnesses. I also want to thank you, Frankie, and the team at Harriet's Wildest Dreams for bringing this to us. Always looking to improve outcomes on whether someone is calling for any type of help, right? And making sure that the appropriate individuals are there for the call. Part of that from an operational standpoint is ensuring that when someone does call, number one, someone is picking up immediately, right? I'm thinking of some of the reasons why people are conditioned to call 911. In most cases, knock on wood, you get an immediate response. In most cases, the call for service is within 10 minutes or so, depending on, availability of officers or an EMT or firefighter in terms of how they're positioned around the city. And, those are sort of the two critical things I would think if I'm talking to a call taker at OUC. They want to make sure that the person on the other end is getting some sort of immediate response. And frankly, some of the statistics around the call response time, whether it be CHAMPS or CRT, could give someone pause. You don't want someone calling for a crisis and then it taking 52 minutes or whatever that might be in order for that person to come. So Lena, I wanted to ask you, because you said your research around these issues, I think constantly you're hearing about Durham, North Carolina, which for those who are not familiar with the Carolinas, I am familiar with the Carolinas. Durham is a strong city, but also a sprawling suburb, if you will. And it covers way more distance than the district in terms of size because of the number of, or how large the county is, rather. In terms of the Durham program, you said they responded to over 8,000 calls, or did you say 9,000? I can remember.
It was over 8,000 in the last year. Over 8,000
calls. Yes. Okay. Have they provided information around whether or not they station their teams at various parts around the county or city, rather, in order to ensure faster response? That's one of the recommendations that we have in the resolution, which is as opposed to all of the teams being in one location out of DBH, that during whatever the particular shift is, if you are, if I have one team in Southeast, one team in Northeast, that allows for a quicker response because you're not having to literally drive across the city in order to get there.
Yes, so I can't speak to Durham in particular. I don't know the specifics of that. Okay. But I'd be happy to provide that in my written testimony. But I do know of others are fine. Other examples across. The one that came to mind is Houston.
Houston.
Yes.
Also large city.
Also very large city, large population. They run a mobile crisis outreach team there. And in fact, they went through some growing pains with this, where they started out with just 2 centralized locations that their responders would dispatch out of. And it led to some really long response times in many areas of the city. And that was an area that they quickly tried to alleviate by opening up more offices around the city, just so that they could have people stationed much physically closer to where most of their calls were coming. So it's certainly, it's a huge, a lot of the effectiveness of these programs comes down to the implementation. It's those details, it's the planning, it's the strong program design, strong community engagement to ensure that you're anticipating these needs and trying to build them in from early as possible.
Yeah. And for other programs, and this is for anyone who's familiar, are the staff who are doing the crisis response, are they also trained as EMTs or could do basic emergency response as well?
As Lena had mentioned, I'm also not fully aware of all the particular details, but the advisory report for Denver, Colorado's STAR team does provide information about the breakdown of who's a part of the team members. They have about 16 emergency response teams right now. They are in their early stages, as Mr. Duckett had mentioned earlier, and they do plan to finance it further so that they can expand that. But they have EMTs, they have licensed clinicians who are able to respond to crises.
And here on a more organizational grassroots level, we do have DC Street Medics who are part of the DC Safety Squad.
Okay. I'm over my time. Thank you. Councilmember Pinto.
Thanks. Thank you all for your testimony. And I heard a lot of consistency in what a lot of you are talking about with the kind of different experiences and expectations that people have when someone is dispatched to really help address their need. I'm curious when you think the line crosses to needing a law enforcement officer to come. And so there have been some examples, for instance, where members of the CRT teams have told me, I called MPD, they called MPD themselves, or they called back 911 to get a dispatch when something was elevated. And as we're thinking about kind of expanding this functionality and training, where you think that type of line should be, that something is escalated, or rather can't be de-escalated from a member of the CRT, and therefore should call law enforcement.
Yeah, I think it's less about where the line is and more about who is the first person that's going to be there. If every single time the first person that you're seeing is a person with a gun, a person who already comes escalated, because guns don't make me feel safe. If I am escalated, I'm not going to then be like, oh, this person looks friendly, they have a gun. And so full understanding that sometimes these calls will need, under this structure, this system that we have, sometimes the police will need to be there or go there, but the police should never be the first person there. And that's what we're trying to say. The first person there should be the person who is trained, who can assess the situation, and not someone who by default is going to escalate.
Yeah, and I'll add to that an example. There was recently an in-depth sort of study of the safety record of the New Orleans kind of non-police crisis response team. It's called MCIU. And they found that that program has a really strong culture of safety and care for their responders. And they're responding in a big city, areas with high crime rates. So it's complex situations. And what they found is those responders feel safe in 99% of their encounters. And they feel empowered to be able to use their training, and they feel that their training is strong enough and gives them enough tools that they can tell when a situation is safe and when it isn't. They're not, making decisions just based on unfounded fears. They use their training, they use their understanding of the clinical presentation of these mental illnesses. And so they feel safe going to over 99% of these situations. And in the small percent of cases where they don't, they feel that they can, choose. They have the power to leave a situation and call their supervisor and make a plan with them on what the next steps are to do. So these programs can be built with really strong safety cultures and giving the responders the power to make those decisions.
Thank you. I also want to ask about our 988 line. It's been a lot of conversation, and some in the last panel talked about this too, this socialization that people get starting as a very young child, that you call 911 if you're in a state of emergency. What do you think is the most effective way to have a more comprehensive education campaign about 988?
I can do it. Well, people think 988 is just for suicide. So that's the part of the issue. It's the branding, the same way that we would advertise when you see something, say something, right? Put it up on the metro, have billboards, y'all can make TikToks. There are different ways to get the information out to the folks, but let folks know that it is an option. I was in a crisis situation, I would say, with a community member about a year and a half ago. I don't call the police. I'm not calling 911 ever. I don't care what the situation is. I'm not going to call the police. I was at risk. And I literally had to physically put my body on the line to keep myself safe, to keep my community members safe, because I knew that if there was a potential, even if it's thin, that if we did call the police, that something worse would happen. 1 year ago, if I knew about 988, I could have called 988 in that situation. And then I wouldn't have been so sore the next day. But yeah, I think that there are definitely ways that we can get the information out, and we'll be happy to work more with both of your offices on how we could do that public education campaign.
Thank you so much. I think that's a great idea too, just even about the re-education of the like more expanded types of services they can provide. Thank you. Thank you all.
Thank you. Yep, thank you. Okay, we're gonna go to our final panel for in-person. Mariah Burke-Rains, Xavier Smith, Anna Jones, and Jamie Potstas. Great. Okay, Mariah, when you're ready.
Thank you for allowing me to testify today. My name is Mariah Burke-Rains, and I'm a resident of
You're going to
Ward-
have to either lean into the mic
Can you
or
hear me better
speak up.
now? Okay.
There we go.
Resident of Ward 5. I'm here to advocate for a humane, trauma-informed mental health crisis response system in Washington, D.C. As a supporter of Harriet's wildest dreams, I believe that community-led crisis response is the key to safety and justice in our city. When I think about police intervention in mental health crisis, I first think of a profound lovelessness. To meet a person in crisis and desperation with law enforcement is shameful and dehumanizing. No matter the training police may receive, they will never have the temperament, historical experience, support, or culture to implement it. I often think painfully about an incident. Mental health crisis is also a natural, healthy response to the traumatizing systems within which we are forced to live. As we grapple with an increasingly brutal and destabilized environment, mental health crisis will only increase. I often think painfully about an incident I was part of nearly a decade ago. A man laid in the alley across the street from my house. He seemed to be either experiencing a mental health crisis or a substance use issue, or both. He was without a jacket or warm clothes in the dead of winter. Without knowing his community or an alternative, I felt that the only option was to call 911 for an ambulance. Knowing the police would be involved, I was terrified that he would be met with violence. If I'd been aware of an alternative to 911, I would have taken it. Needing help is not a crime, and there should be a widely known venue for that. Luckily, he was taken to the hospital without incident, but it could have gone either way. We have an opportunity to reject our current reality and join cities like Denver and Oakland and like Camden, which disbanded its corrupt police department in 2012 and created a new force prioritizing community policing and de-escalation. This led to reduced violence and better mental health outcomes. We can reimagine public safety here in our city too, and have a counterpoint to extreme militarization and the broad use of police across the country. The People's Response Act calls for federal investment in non-police crisis response and community safety initiatives. We know based on the success of programs like Denver Star and Oakland's Macro that creating response teams and facilities that prioritize health over punishment leads to better outcomes. The council has the power to ensure that mental health crises are treated as public health issues and not criminal matters. I urge you to support the full implementation of the People's Response Act and commit to a community-centered approach to crisis response. Thank you for your time.
Thank you. Xavier? Just turn your mic on. There you go.
Thank you. Good afternoon, Chairperson Henderson, Chairperson Pinto, and members of the committee. Thank you for the opportunity to address you all today. My name is Xavier Smith, and I am a member, supporter, and safety organizer with Harriet's Wildest Dreams. I am also a student at Howard University, currently studying under the Howard School of Social Work and a Master of Social Work program, focusing on community administration and policy. I am additionally the father of a neurodivergent 6-year-old who I must constantly consider when framing my interactions with police and the state at large. Today, I'm testifying about the need for the city to overhaul the current mental health crisis response system and prioritize the health and safety of DC residents. Our current response system increases the likelihood of engagement with law enforcement for our neighbors in their most vulnerable moments. Mental health crises should be approached as a public health matter, not a judicial issue. Community engagement in crisis response can make all of the difference for a community member in need because, again, as was said before, we keep us safe. This work is deeply personal to me as someone who struggles with mental illness. Since childhood, I've been made aware of the stigmas faced by Black and brown individuals who share in my experience. I was always told to be conscious of how I presented myself in public, to be mindful of my behaviors, and essentially I had to learn to mask to survive. Concealing and suppressing aspects of my identity and neurodivergent traits to make myself more agreeable to strangers and to stay safe was the only way that my parents could ensure that I returned home to them each day. This conversation happens in different forms, but along the same baseline every day in Black households. It is not foolproof, and historical examples exist of Black people being in the right place at the right time and doing the right things, and subsequently still ultimately losing their lives at the hands of law enforcement officers not equipped to respond to the various behavioral factors that preclude negative interactions with agents of the state. This was the extent of their attempt, as far as my parents were concerned, to exert control over a fate that would ultimately be intertwined with law enforcement throughout my life, both inside and outside of the district. My earliest memories are of being raised in an area familiar to Black residents of DC, not far from a landmark called the Shrimp Boat near Texas Avenue Southeast in the 90s. As a young man at my father's side, I witnessed the neglect shown to Black folks in my area, neglect that did not manifest in other parts of the district that were not populated by as many people who looked like me. There was a clear need for monetary resource-rich support for comprehensive mental health services and enhancement of community initiatives to serve Black people across the city. Yet, even then, it felt like a secondary priority to the city's governing parties. What seemed to take precedence, and still does, is the visibility and presence of police throughout predominantly Black neighborhoods like mine across the city. There was a near constant police presence in the neighborhood where I was raised, and most of that presence was directed punitively toward Black residents. In the years that have followed, strides have been made through the work of community organizations like Harriet's Wildest Dreams and others, and like-minded law persons in the district, but forward progress is an uphill battle, and for every victory there have been losses of both life and progress. One is preventable, the other is inevitable. Criminalizing individuals with substance abuse issues or those in the throes of mental health crises fills quotas but destabilizes communities. The ends do not justify the means. The collective gains nothing by underserving our most vulnerable populations. Disproportionately, Black people are overrepresented in the criminal justice system, even more so when it comes to mental illnesses. The most recent data available from the Bureau of Justice Statistics shows that more than 1/4 of people in jail meet the threshold for serious psychological distress, and nearly half of them have been told by a mental health professional that they have a mental illness. Carceral facilities are not the appropriate destination for those who need mental health support, and community members deserve better support from the city than constant policing. Community safety initiatives that do not involve law enforcement as a first response are essential for fostering a supportive and secure environment where individuals can seek help without fear of criminalization. Reinforcing community-based response systems such as the 988 campaign, which prioritizes an alternative to an immediate police response to mental health crises, promotes the creation of safe spaces where individuals can receive the care that they need without the fear of legal repercussions, prioritizing health over punitive measures. These initiatives also empower communities and create a network of support among residents. By training community members to respond to crises rather than relying on traditional law enforcement, faster interventions become a tangible possibility as community-led responses are more efficient in utilizing local resources and knowledge, effectively mitigating crises before they escalate into situations that require police intervention. When mental health, substance abuse, and other issues are treated as public health concerns rather than criminal matters, communities are more likely to adopt preventative measures, which ultimately may have a larger positive impact than reactive ones. Empowering communities with crisis intervention specialists who are properly trained to assist with their unique needs decreases the need for an intrusive, consistently present police presence that ultimately puts more lives in harm's way than it saves. I thank you, Chairperson Henderson, Chairperson Pinto, and the committee for allowing me a moment of your time and consideration.
Thank you. Ms. Jones.
Thank you so much, Council and Chairperson Henderson and Chairperson Pinto for having us today. My name is Anna Mabel Jones. I'm a woman in long-term recovery. And what that means for me is I haven't picked up a drug or any mind-altering substances since August the 30th, 1999. Because of that, I stand before you today as a wife, a mother, a native Washingtonian who votes, a sister of a brother who deals with chronic mental illness, and a person who advocates for people who are ready to change their lives. I'm honored to be here today to talk about some things that Community Bridges, our newest stabilization center, is doing to better serve our community. We're doing it twice, so I'm going to try to go sort of fast with what my part. So I just wanted to talk about the expansion, and the expansion is the new level 3 recovery residency. We know in DC, we don't have a lot of housing as a major need. So we have just opened a level 3 recovery residency, which is Fellowship House. We know that there are 4 different types of recovery housing, and this particular house is a level 3. It is a safe and supportive place where individuals struggling with stimulant use disorder or opioid use disorder can find their path to recovery. That's exactly what the CBI Fellowship House aims to create. A recovery residency designed to nurture growth, safety, and recovery, helping individuals transition into independent and fulfilling lives within their communities. At the heart of our approach is a deep commitment to understand and supporting each person's journey. We believe in treating each person with dignity and respect, tailored our support to their unique needs, goals, and strengths. Our recovery plans are flexible and evolve with each individual's path, ensuring they feel supported every step of the way. CBI House is a level 3 recovery residence and is the cornerstone of care for those overcoming substance use disorder, offering a stable and supportive environment that fosters lasting recovery. Our motto is built on power of community. We foster peer support, accountability, and engagement. And I just want to state that we're dealing with all agencies, even to help people suffering with co-occurring disorders, because we know a lot of times the people with mental illness have a substance use disorder too. So sometimes they really go together. We need to make sure that we're addressing that as far as the trauma-informed part. Also, we've been granted to do outreach and navigation, and we're doing that in Ward 7 and 8, which we're really excited about because we're tapping into meeting people where they are and going in the community and addressing it. I can truly say it was so exciting to hear about 988 because we are utilizing that. And through SAMHSA, They do, I want to say they do have a campaign going that we can utilize those resources in Washington DC to get a lot of that, to add on to what will be happening with some of our agencies. Amazing things are happening with that. And I think in DC, we can take advantage of a lot of things that are happening with 988 that we haven't started utilizing yet. Thank you for letting me share.
Thank you. Ashley, if you can take that remaining 1 minute and 30 seconds and add it for Jamie. So you guys are splitting time.
Thank you. Good afternoon. My name is Jamie Pottis, and I'm with Community Bridges, Inc., who runs the Stabilization Center over at 35K. Thank you for having us today. The Stabilization Center has been open since October of 2023 and continues to serve folks experiencing a substance abuse crisis 24/7, 365. Substance abuse crisis services play a crucial role in supporting the health and stability of a community. During the short time we've been providing services in Ward 6, we have successfully collaborated with FEMS in ensuring their patient drop-off time to the Stabilization Center is under 5 minutes, which releases them back to the community to where they're most needed. People experiencing substance abuse crisis is best done outside of the emergency room. Basic medical care can be provided at a Stabilization Center, which helps prevent unnecessary emergency room admissions. We have a variety of MOUs with community behavioral health and medical providers to ensure that patients have a comprehensive discharge plan to hopefully prevent the need for crisis services in the future. Warm handoffs play an important key in making sure the person who was previously in crisis is able to connect to their community support team. With that being said, we aim to provide an environment for both patients and family members which welcomes them back should they need crisis services again. Thank you.
Thank you. Hey, thank you so much to this panel of witnesses. Thank you for your testimony and for sharing your own personal experiences, which is very vulnerable to do that in a very public setting. So thank you for that. Ms. Jones, hi, good to see you again. I'm obviously familiar of the work that you all do at Community Bridges and our stabilization that's at 35K Street. Someone knows someone who might be in need of the services there. It's very interesting to hear about this new endeavor of Community Bridges, which is the level 3 recovery residence, which is different than the Stabilization Center, which is temporary in nature, to truly the definition of stabilizing someone and then connecting them with other forms of care in the community. When do you all fully launch with Fellowship House, and how will referrals happen for that location?
Great. So we recently, last Friday, we had our house opening. We actually have a waiting list from that house opening from a bunch of different places in our treatment providers, some of the respite houses. We are in silos sometimes when it comes to housing. So I'm trying to just understand respite, recovery, stabilization center, respite, recovery housing, like the different levels, levels 1, levels 2, levels 3, levels 4, and then maybe 1, 2, and Oxford House. But hopefully we'll be opening officially next week. And I think we're going to be full. That's just showing the need and how many, how it needs to be more different types of recovery housing. So,
and how many beds?
We have, excellent. So we have 10 beds and we have 6 singles and 4 doubles. Because a lot of people in DC, I'm one who lived in a recovery house, right? And I truly feel it saved my life because those women kept me on track. They did not let me, they were like, you're not going to do this. Been there, done that, not happening, Ms. Jones. So, but it's great to have like more single rooms so that people have some time so that they can connect and, have their own privacy because everybody recovers at a different pace. But it's also good to have doubles so that you won't isolate. Yeah.
Right.
Oh, and it's a men's house.
That was going to be my next question is single gender, et cetera. Because I know from the data that you all get from, or that we see from the Stabilization Center, the vast majority of individuals that you see are men, correct?
Correct.
Okay. Now I'm not going to put you guys on the spot to ask about a second location because that's not really you per se. It's more on our end of things, but I am curious your thoughts around, there was earlier witness testimony that talked about needing a stabilization center specifically for mental health crisis. Now, obviously, you all see patients who might have co-occurring disorders, right? Whether it is alcoholism plus that, or something in terms of substance use plus other issues, et cetera. Community Bridges is not only in DC, it operates around the country, but are there models that exist for that?
Yeah, so in Arizona, we have over a dozen crisis-based programs that serve both mental health and substance abuse. It's kind of like what came first, the chicken or the egg. So we work hard in providing those co-occurring services for both voluntary and involuntary folks.
Okay, but in those settings, is it temporary in nature? So
Yeah.
another type of descriptor of what some have been advocating for here is an urgent care that's specifically geared towards behavioral health.
Yes.
So it's sort of like, you don't need an appointment, you can see
Correct.
someone that day, X, Y, or Z.
Yeah, so we have programs where you can walk in kind of like you would in urgent care and be in and out within a couple of hours. Like you really do need a short-term prescription, and then we'll connect you to an ongoing outpatient provider. And then we also have crisis programs where folks who need a little bit more stabilization and need that monitoring. Those are for up to 23 hours and 59 minutes, knowing that we're never going to discharge you if you're still in crisis and your discharge plan isn't wrapped up yet. We'll continue to work with you to get you where you need to go.
Okay, and in the places, the cities where you operate in Arizona, do any of them have the crisis response teams that we've been talking about earlier today?
Yeah, 100%. We do a ton of, we get a ton of drop-offs from those crisis mobile teams or crisis response teams all day, all night.
Okay, thank you. Councilmember Pinto.
Thank you. Thank you all so much for your testimony. And a number of you mentioned this idea of community-led crisis intervention. And I'm curious if you can elaborate a little bit more on if you think even at those first instances, is that look completely separate from any sort of government involvement? Or is that meant to be more of is that a different term of art used for a type of government involvement that you're envisioning?
So I can speak to a little bit about what Arizona does.
Okay.
Most of the first responses are done by those crisis response teams without police. Of course, there are instances where police may activate the crisis mobile team themselves.
But I'm sorry, are the crisis response teams out of Arizona still government employees?
No, they're operated by individual
completely-
providers.
okay.
Yeah, the funding's a little bit different out there.
Got it. Okay. Okay. Thank you. That's helpful clarification. And then as we think about the substance use disorder treatment and the follow-ups, how are you monitoring if an individual kind of needs additional support later or knowing where they can turn to? Do you track those kind of medium to longer term successes?
Yeah, so we have the opportunity to call people at certain timeframes, like the 24-hour mark, the 72-hour mark, the 1-week mark. One of the biggest challenges, though, is people with working cell phones. Also, them answering for a number they don't know. So we do some familiar faces with local providers, and those are for folks who come in frequently to our facility 3 or more times over 90 days is someone who is a familiar face to us.
Mhm.
We'll work with those providers on an ongoing basis to ensure their people specifically are getting their needs met. These are something that the stabilization center is meeting that they're not getting on the outside. So we'll work with them to make sure that they are hooked up appropriately to no longer need crisis services.
Okay. And as we hopefully build out a second location and explore expansion of these services, what are some lessons learned that you've realized or seen, maybe that you didn't anticipate in having this operate?
Well, we've been doing this, Community Bridges specifically has been doing this for 42 years in Arizona. So we have learned a lot of lessons probably in Arizona. I think we've had really great collaboration with community partners. So I think utilizing some of those partners that we didn't know they did A, B, or C in the beginning, now we know exactly what they do and how to refer to them appropriately, will be beneficial in a second center if Community Bridges was awarded it.
I'm going to add on to that and say, I think community is really important. And it's been for the Stabilization Center in DC, it's been major, working with community, the MOUs, making sure that that connection is there, not just with treatment centers, but with prevention, with mental health, with all the different agencies in DC. It's been a true, love gathering, you know, once they hear this is new and this is something that we've never had before. So that's the unique thing about it, because dispelling the myths, I think in DC, if it's not a treatment center, it's not that, it's actually a place where someone can come, you know, that's going through a crisis and stabilize and get time. And it's actually a place where when we say no wrong door, we mean it. And I can say as a person in recovery, and I've been through a lot of treatment centers in DC, that you're 3 times and you're out. You're not coming back here. You just can't get it, all right? But it's not like that today. It's more different. It's like we understand that you never know when a person is going to be, you know, change their mind and say, hey, I'm ready to try that. And not just one way, just having a lot of different pathways, because we do have a lot of awesome resources in DC to give to people. So that's a great thing to know too.
Right. Great. Okay. Thank you. Thank you all. Oh, sure.
Thank you, Chairperson Pinto. I had a thought that I wanted to bring up when you asked about I guess, the difference between a government-led initiative versus community involvement. I think having being a member of the community, I feel like folks would feel a lot more empowered if you were providing them adequate training to be able to take charge in mitigating crises in their own immediate environment before the government becomes involved, than essentially having someone go in and do and essentially strong arm the work for them. I don't believe that there's not room for a happy medium, but having it just be one-ended in the sense of the government running everything has not worked historically as far as the underserved communities in the district are concerned. And that was just the one thing I wanted to offer.
Thank you very much. Thank you all.
Thank you. If you haven't provided your written testimony, just make sure you upload it for the record. Okay, we're going to turn to our virtual witnesses. So for those who are listening, it's your turn. If you haven't joined us for our virtual witness, a virtual witness, you have to affirmatively accept our invitation to become a panelist. Given the number of individuals that we have, and we do have one in-person person who there had some car challenges, and so going to move to virtual. We're going to do panels of 6. Rachel White, Gail Avent, Tia Bell, Dr. Marie Morales-Black. Shannon Walsh wants to go at the end. Andrea Proscianino. Apologies, Andrea, for getting your name incorrect. And Chioma Ora. Okay. Again, you have to affirmatively accept our invitation to become a panelist. I know. Actually. Okay, great. All right. All right. We'll see Rachel. Rachel, if you want to get started.
Yes, thank you. So good afternoon, Councilmember Henderson and Councilmember Pinto. My name is Rachel White, and I serve as the Deputy Director of Youth Advocacy at DC Action. I am here today to express my strong support for the Council resolution supporting humane and trauma-informed responses to behavioral health crises, because improving our crisis response system is critical for the well-being of all district residents, but particularly youth. Mental illness is not a crime, yet our current system often treats it as such. Law enforcement officers are not trained to respond to behavioral health crises in ways that de-escalate situations, as you have heard today. Unfortunately, this results in unnecessary hospitalizations, criminalizations, missed opportunities for effective intervention, and sometimes death. The gaps in our current system disproportionately impact young people who are systemically involved in whether it's the child welfare system, juvenile justice system, or youth experiencing homelessness, who often lack access to stable support systems and are more likely to be criminalized for behaviors linked to trauma and unmet mental health needs. The current crisis response system fails our youth and communities. You've heard a few data points today, but just want to highlight again that calls to 988 and the DBH Access Helpline frequently go unanswered or are rerouted to 911, delaying care and defaulting to police involvement. Just last week, my colleague and I saw a youth in a mental health crisis. And so community members were around him trying to intervene. And so we took it upon ourselves to call 988 and were instructed that MPD would be on its way. In addition, the district lacks sufficient community-based crisis beds, short-term observation units, and respite centers, leaving many individuals, particularly youth, without safe places to stabilize. So key reforms in the resolution lays out critical reform to create a care-first approach to behavioral health crises. Specifically, it would improve crisis call response, ensure that calls are answered within 20 seconds to prevent unnecessary police intervention, expand and support mobile crisis teams, hopefully fully funding and staffing to ensure high priority calls receive a appropriate response. And provide culturally and linguistically appropriate services to meet the needs of diverse populations. The resolution would invest in crisis stabilization and alternatives to hospitalizations and ensure that youth and families have a say in their care, which is extremely important. To close, youth in crisis should not have to rely on police officers to get help. The council resolution presents a clear and actionable plan to ensure that every resident, especially our most vulnerable young people, receives the care they need when and where they need it. So I urge the council to pass this resolution and fully invest in a care-first, trauma-informed approach to behavioral health crises in the district. And thank you for your time and flexibility today. And I'm happy to answer any questions.
Thank you. All right, I don't see Gail, but I do see Tia, if you're here.
Yes, thanks, Chairperson. Good afternoon, Chairperson Henderson and fellow council partners in prevention. I am the founder and CEO of the Trigger Project. We are working with and for youth to shift blame to understanding for people behind, in front, and around the gun. We have curated cross-sector partnerships with government organizations in the district and national institutions of education across the country, including the University of Michigan, to study, identify, and mitigate risk factors associated with youth violence. Our goal is to reach the youth and the youth ecosystems to provide research and evidence-based practice that will build a future almost void of interpersonal gun violence. Today's opportunity to share couldn't have come at a better time. As a native Washingtonian and community organizer, I'm personally and professionally inspired by Chairperson's introduction of such an important resolution and all of the council's support. We see this hearing as a chance to truly break ground in addressing the treatment of our city's healing and protection as it relates to behavioral health crisis response and ultimately prevention. Gun violence is a behavioral and public health crisis, as well as the source of our city's fragility and heaviness. The CDC recognizes gun violence as an injury and a disease that spreads through model behavior. The Trigger in the Trigger Project compassionately states the true reasons I grabbed the gun evolved from risk. In 2019, this bold initiative was birthed in collaboration with young, brilliant minds who were all survivors of gun violence and all experienced detrimental gaps in services and unmet needs across our government agencies. I know and watch youth live firsthand the challenges and risk factors associated with gun violence. I regrettably see what happens when we respond to trauma with punishment instead of care. I am privileged to see what's possible when we lead with compassion, consistency, and care. Too often, when a young person is in crises, whether it's grief, trauma, or behavioral health need, the response is slow, disconnected, or harmful. But the truth is, behavioral crises does not clock out at 5 p.m. They happen late at night in schools, in homes, and we can't expect healing to happen without systems of support being available or empathetic when it matters most. We hear repeatedly that this agency doesn't do that, or they don't serve them, or there's a wait list, or that this person can do it, but they're over capacity, or that the organization can't afford it, or that the grant doesn't allow it. We need 24/7 trauma-informed humane responses to these moments. And more than that, we need to understand that the underlying needs of the whole family, not just the one in crises, or in our language, the person in front or behind the gun. We too urge Madam Mayor Bowser to take decisive action in improving the crises response services, reducing unnecessary police involvement, and expanding access to trauma-informed care. We believe this resolution allows our city to truly heal from within and provides an opportunity to collaborate and resource community-based solutions and interventions. In collaboration with some of our competent partners who you've seen today, but other partners like Domestic Violence Wears Many Tag, 1-800-Homicide number, the Sober Living Project, Bold Yoga, Streetline, and Harriet's Wildest Dreams. They could all address the missing pieces that have been stated today, and with proper funding could consistently meet the needs that we see on the ground. My prayer is that you uplift and invest in community-led solutions because they lead to the economic opportunity that we need to fill these gaps that the ones DYRS, CFSA, MPD, other agencies in public health and policies leave. The infection of gun violence and the cycles of inadequately treating crises have penetrated our city's pride and sense of safety. Reactively addressing gun violence and behavioral crises with public safety strategies has served as a contagion. It is vital that we strategize collectively to work to get ahead of constantly operating out of crises. This requires centering youth violence prevention through a public health lens and making real investment in primary prevention. I'm asking for your support in the implementation of our Trigger University model in partnership with the Trigger Project, which would serve as a physical space for 24/7 trauma-informed access to protection, therein increasing a pipeline to prevention. A space where young people could feel safe, seen, and surrounded by care and not cuffs. In increasing financial support for youth prevention and protection work, young people could see a model behavior rooted in care and consistency, with the ROI leading them to believe in their own selves and futures. Instead of modeling behaviors that amplify youth victimization and perpetration, in the midst of crime going down, youth will begin to model care for others. This is a cycle we want to fuel. At Trigger, we're not waiting for systems to change. We're building the future our youth deserve in a present where they can navigate the systems until they are changed. But we can't do it alone. We need investment, partnership, and political will to treat youth violence as a public health crisis. Currently, most interventions trigger our youth and our community members. In trauma-informed care, the opposite of trigger is a glimmer. When agencies are driven versus burdened by community voice, we can build a city with trauma-informed cultural responses and ultimately create individuals who contribute to a world absent from the disease of gun violence. Framing our response to violence and behavioral crises through the lens of healing versus criminalization could not only treat the whole individual, but would eliminate the system inequities at the root and reduce the barriers, aka the risk. Thank you, Council, for supporting a public health approach to our
Thank you,
trauma.
Tia.
We are prevention and we keep us safe.
Thank you. All right. Dr. Morris Black. Marie, if you're speaking, you're on mute.
Good afternoon.
Good afternoon.
Can you hear me?
Yes.
Good afternoon, Chairperson Henderson, Chairperson Pinto, and members of the council. Thank you for the opportunity to testify at this joint oversight roundtable on trauma-informed crisis response for the District of Columbia residents impacted by mental health and substance use illnesses experiencing an adverse behavioral crisis. My name is Dr. Marie Morales Black. I am the CEO for MBI Health Services, one of the largest behavioral health services in the district, serving over 10,000 district residents, children, and adults. Today, I am testifying on my strong support for the resolution on that the council has put forth on supporting humane and trauma-informed responses to behavioral health crisis. I know this hearing is about crisis response, but as a clinician and CEO of MBI, I can attest that when mental health providers engage consumers enrolled in quality services, such as quality community-based services, therapy, medication management when warranted. It reduces crisis and thereby reduces the number of interaction between the police and mental health consumers. So prevention first. I also understand and can attest that even when the best efforts, some of our residents, adults, or children impacted by mental health and or substance due to ongoing treated or unresolved trauma will have periodic episode leading to crisis. In those instances, I support a more coordinated crisis response by having 911 dispatch trauma response teams for mental health crisis calls. It is important that people with expertise in de-escalation and crisis management to work with those individuals with backup from police when necessary to manage those crises. There are many successful programs with good practice evidence around the country, some of which may have been mentioned already. I have not been able to listen to the whole thing, but like Arizona, Denver, Rochester, and Durham, etc. Also, Dr. Bruce Perry, the author of What Happened to You, is a trauma expert and has written on brain hierarchy of development. Its inverted pyramid program, which explains in simple terms the complex of the brain, talks about the correlation between trauma, the impact of its brain, and how people act when they are threatened. People's natural response to threat is fight, freeze, or fight, which inherently conflicts with how police may interpret those responses. Our stress response is housed in our lower brain, and the lower brain does not, once it reaches a level of threat, it's really hard for people to be really thinking. You're no longer able to think before you act. The sense of time shrinks and your functional intelligence decreases. The police are not trained trauma experts or mental health experts, nor should we expect them to be. Police expects people to follow their orders and think through rationally. When people are traumatized, they are not able to do so. Thereby, again, a reason why we should have a clinician and folks that are expert in trauma and de-escalation to be first responders for our community. The Durham program, known as the HEART, Holistic Empathetic Assistance Response Teams, has gotten good reviews and have shown some really good evidence. Since they've been in operation in 2022, they've received over 26,000 calls, and there is a big push in the last couple of weeks to have it moved to the whole county. I am suggesting DBH already has a CRT team that is supporting, although the timing based on what the little bit of research I've done shows that it's almost an hour. I think that they already have the foundation to really embrace and support this. However, it needs to be reimagined similar to some of the best practices around the country to reimagine it to meet this need. I do further want to share that the Durham program has a navigation coordinator attached to it, which really helps to ensure the connection of those in crisis back to their provider and or to connect them with a new provider. And we found that with the PEPV during the COVID, having someone to really reconnect people to their provider agencies really worked. However, we also have to make sure that once they get to those provider agencies, that they are receiving the services that's going to help them to stay stable, and they are getting their medication management that they need. I think that having a coordinated approach with DBH and the police and having direct dispatch is the way to go, and I 100% support this program, the resolution.
Thank you.
And I'll be open to any questions that you have.
Thank you.
Madam Chair.
Andrea?
Good afternoon. Can you hear me?
Yes.
Okay, I just having a little computer issue here. 1 second. Okay. Good afternoon. My name is Andrea Procaccino. I'm attorney at Disability Rights DC, and I thank you, Councilperson Pinto and Councilperson Henderson, for allowing me the opportunity to testify today. Our testimony today is going to focus on the need to improve the Access Helpline and 988 services, the Department of Behavioral Health's mobile crisis services for adults and children, and assertive community treatment or ACT teams, which are services for adults and intensive community-based services for children in the district. Before committing to expensive institutional alternatives, the district should actually and effectively implement sufficient community-based responses. Any respite alternatives and community-based services must prioritize dignity and trauma-informed practices. Disability Rights DC is concerned with the council's findings that in 2022, the police department responded to over 36,000 behavioral health calls rather than the Department of Behavioral Health Crisis Response teams. Of equal concern is that 911 calls are frequently not diverted to a response provided by DBH due to DBH Access Helpline's delayed response to answering calls. If the current number of behavioral health crisis calls annually are similar to 2022 number of 36,000, DBAs clearly must implement a significant expansion of Access Helpline 988 system to meet the demand. And the mobile crisis team's current capacity must also be expanded. Calls concerning behavioral crisis, which can be resolved with a peer professional response using a trauma-informed approach and respecting the dignity of the individual, should be diverted to the district's behavioral health crisis teams and away from police responders, which has been testified may not have the adequate de-escalation skills and which can result in criminal charges. The Access Helpline must respond quickly to urgent calls and ensure that mobile crisis teams are dispatched when the caller asks for on-site help. Moreover, as stated in the resolution, it's critical that DBH, the caller to 988 and Access Helpline, including those diverted from 911, receive this a warm handoff to community health services, and crisis responders staff remain on the line while connecting caller to providers and should not disconnect until the caller is speaking with a provider. The CHAMPS or the child serving crisis response should also ensure that children are not only connected to a provider, but receiving treatment and connected to intensive behavioral support services and intensive care coordination, if needed, to avoid institutionalization. As the committee notes, the MPD currently responds to the vast majority of behavioral health calls. Although DBH staffs and implements the current mobile crisis teams to reduce reliance, it's failing to implement these services adequately. Disability Rights DC is unaware of DBH behavioral crisis providers other than the CHAMPS, which is only available Monday through Friday, 8 to 8, and the community response teams. Nevertheless, in 2021, DC adopted regulations regarding certification standards for behavioral health stabilization providers for adults and youth. And these standards set out requirements such as provide rapid response and assessment of treatment behavioral crisis situations, be an on-call 24 hours a day, and other important requirements for crisis intervention. And additionally, the core service agencies are now required since 2023. There's new regulations that mandate the core service agencies provide independently licensed qualified practitioners to be available 24 hours a day, 7 days a week for telephone, face-to-face, and mobile interventions. DBH should ensure these core service agencies are providing these services. So in other words, the ACT teams, we aware that ACT teams who provide intensive services are required to also provide crisis services, and under the new regulations, the all core service agencies have to have this ability to respond to crisis. And we think this should somehow be coordinated, working with DBH to make, it could be an extra resource in the community to provide crisis service to those who are already being served by core service agencies or ACT teams. And that, like an ACT team, the core services have to be available 24 hours a day to provide face-to-face mobile interventions. So DBH should ensure that the ACT teams are providing the services as well as what I just mentioned, which is that DBH.
Andrea, you're about everybody has been over. So I was, if you could just wrap up.
Okay, so sorry. You know, we fully support the resolution. We think DBH must prioritize robust and effective mobile crisis teams and invest in the community-based behavioral health services, should precede any investment in institutional placements or creation of facilities. And as stated in the resolution, every individual in crisis deserves timely, trauma-informed care from culturally and community competent behavioral health professionals.
Thank you so much.
Thank you for your time. I'm happy to answer any questions.
Thank you. I think we've been joined by Gail.
Yes.
Thanks, Gail. If you want to go ahead.
Yes, thank you. And thank you, members of the Roundtable, for the opportunity to provide testimony today in support of the creation of a humane and trauma-informed response for behavioral health crisis in the district. My name is Gail Aden. I'm a mother, a grandmother, and the CEO and founder of Total Family Care Coalition. I'm also a resident of Ward 7. We provide holistic and person-centered services for families and youth. Our mission statement was drive our approach to keeping families together for a better and safer community. We have trained peer support workforce committed to building lasting relationships, being good listeners by supporting families and youth to ask for help they need. We support needs. Moreover, I support legislation which creates the humane treatment of all individuals in crisis, especially youth and children. The one service that parent could rely on for youth crisis was CHAMPS. Now it is replaced by MPD or DBH Community Response Team. MPD, crisis intervention officers, should not be the one who lock up parent or youth. And the community response team is not trained to work in youth crisis. I agree with Sampson that a crisis response team system should have somebody to talk to, someone to respond in a timely manner, and a place to go. The place to go for children and youth is a place familiar with youth needs in children. So I am proposing a children's psychiatric emergency program, children's CPAP. A children's CPAP can provide diagnosis to undiagnosed mental health and substance use problem, and the child can be eventually sent back to the home with the parent understanding how to support their needs and not being sent outside the city for help and away from families, further destroying parental relationship. Research shows children and families do better when they heal together. I know from a personal perspective how system with their best intention can be devastating to families. My staff and I hear daily reports from parents who want their children to be productive members of society, to have a future, dreaming past daily challenges of fear, pain, and loss of loved one. We help families, one family at a time as best as possible under the circumstance. TFCC's greatest accomplishment with families is the ability to build trusting relationship without shaming and blaming them for not knowing what they should know. We support them on using their voice to get what they need to be successful in the community. Furthermore, we are strong supporter of understanding systemic care enhancement can take time, and we want to remind policymakers to include our voice. Making system changes, in other words, nothing about us without us. Again, I encourage parents and youth to have a voice in the development, review, and of the usefulness of a youth-focused trauma-informed crisis service system in the district. Finally, I hope that creation of a children's mental health crisis service includes input from the families and the youth. I'm happy to answer any question that you might have. Thank you.
Thank you. Thank you to this panel of witnesses for your testimony. Really appreciate hearing from the work of people who are on the ground and some of the advocacy that you all have done around crisis response. I don't have any specific questions for this panel, but I'll turn to Councilmember Pinto.
Thank you very much. I just wanted to ask about a gap in our current services available to youth, and kind of what the panelists think about areas of opportunity that we have to offer, kind of similar to the stabilization center, but a kind of crisis response to address youth having mental health challenges.
I can speak directly with respect to youth experiencing homelessness in the district. So one of our main goals is to address mental health before it even reaches a crisis level. And so we've been testifying to this for like the past few years, but youth who are experiencing homelessness and receiving services through a shelter or a transitional housing, not all of those programs have mental health services on site, and there's barriers to accessing supports in the district. And so we have been a proponent to bringing mental health services to youth where they physically congregate on a consistent basis to address mental health concerns, and if not that, to at least provide linkages to mental health supports if they're not able to provide like the therapy and counseling on site.
I just want to say that mental health is not simplistic. It's very complex. And because of the times that we're living in, because of the family makeup, there's a lot of factors that go into why children end up in crisis. They may not have no one to listen to, they may be parenting their own parent who have mental health substance diagnosis. Are they feeling alone? They haven't been included in grief and loss process when they lose a loved one. So, I want this committee to think there is a simplistic answer to address for mental health. It's not. It's very complex, and it takes complex and innovative approaches to providing services for families and youth who are in crisis in mental health.
Yeah, I would like to add to both of the ladies, echo both of the ladies' sentiments. We train our youth who are 18 and over in youth mental health first aid in partnership with Harriet's Wildest Dreams in the University of Maryland. I think that would be a way to just equip youth to help them understand and recognize the signs and symptoms of mental crises. And then, of course, I'll just echo again the Trigger University model. There's nowhere where youth can call or go or have access to support 24/7. And yeah, I'll just leave it there.
Yeah, now we would just like to add, I would just like to add that, it would start with CHAMPS. CHAMPS is just 8 to 8 now, and that's certainly not adequate. And CHAMPS could be a real key in coordinating services for children, getting the services they need to remain in their homes. And, it's like other panelists said, it's a complex problem, but the services in the district for children to get the services to prevent even a crisis aren't there. And then the services, if they have a crisis, to have the mobile crisis go out, CHAMPS go out, or it's just not enough. Not enough now. We need more. It needs to be 24/7, and it needs to be a really robust team that looks at the whole child and gets them the services that they're going to need, and make sure that they're connected with an agency, a provider agency, and make sure that the parents have help to follow up and those kinds of things. So yeah, it's not adequate right now. The children aren't getting the services. They're ending up in being institutionalized needlessly, and with focus on this kind of issue will help prevent that.
I can add, as a provider of children's services, I think that several years ago, there's been significant reduction in intensive community-based services for youth and children, which has an availability of 24-hour crisis services. And part of it is because several years ago, we decided to make the people providing those services must be licensed, and when it isn't in any other part of the country. And as a result, it has significantly reduced the workforce that can provide those services to really support the families of the district. I know for us as a CBI and a multi-systemic therapy provider, which we recently had to suspend because of staffing and because of the business model, and it really makes it hard to provide those services when any part of the country it's talking about an interdisciplinary team, yet here you must be licensed in order to provide those services, which has then reduced the likelihood of those services, particularly on a fee-for-service model.
Okay, thank you. That's helpful. Thank you all very much.
Thank you all on this panel. We're going to go to the next panel. Jamila White, Adelaide Robb, Dr. Patrick Canavan, Kevin Kramer, Christy Balak, and Shannon Walsh. Okay, I don't see Commissioner White, but I do see Dr. Robb.
Do you want me to go, or are we waiting for the commission?
Go ahead.
Okay.
All you.
Good afternoon, Chairperson Henderson and Chairperson Pinto and members of the Committee on Health and Judiciary and Public Safety. My name is Adelaide Robb, and I am the Chief of Psychiatry and Behavioral Sciences at Children's National Hospital. Thank you for the opportunity to provide testimony in support of PR26-0108, the sense of the Council on Supporting Humane and Trauma-Informed Responses to Behavioral Health Crises. At Children's National, we understand the profound impact that behavioral health crises can have on children and their families. The situations often involve complex mental health conditions, trauma, or substance use issues, and require interventions that are not only clinically sound, but also compassionate, understanding, and tailored to the unique needs of children. Too often, children and families experiencing a mental health crisis are faced with systems that unintentionally escalate the situation or perpetuate harm. For children, experiencing a mental health crisis can be terrifying and overwhelming experience. Without appropriate care, these crises can lead to long-lasting trauma, exacerbating their struggles and impeding their ability to recover. We have seen firsthand the benefits of trauma-informed community-based approaches to managing these crises through working with the Child and Adolescent Mobile Psychiatric Services, or CHAMPS, led by the DC Department of Behavioral Health. This emergency service provides specialized interventions that meet children where they are, whether at home, in school, or in the community. CHAMP's approach aligns closely with the principles of trauma-informed care, ensuring that children in crisis receive the appropriate mental health support in the least restrictive and most respectful manner possible. The CHAMPS team has been incredibly responsive, and we typically call on them in the emergency department to assist with assessments for admission that may require an FD12. In the past 8 months, we have not had to wait longer than 30 minutes for them to arrive. Their quick response ensures that children in crisis receive the necessary assessments and interventions in a manner that is supportive and fosters a sense of safety in a time of intense distress. Children's National supports this resolution as it strengthens the district's response system and promotes community-based, trauma-informed care. We believe that by prioritizing training and policy reforms, the district can foster a trauma-informed response framework. This is crucial not only for the immediate well-being of our children, but also for the long-term health of our communities. Children's National remains fully committed to supporting initiatives that improve behavioral health responses in our community, and we believe that through continued collaboration, we can build a system that is both effective and compassionate. Thank you for the opportunity to testify, and I'm happy to answer questions you might have.
Thank you. Dr. Canavan?
Good afternoon, Chairpersons Henderson and Pinto, members of the committee. I'm Patrick Canavan. I'm here today as a neighbor from Ward 1, a licensed clinical psychologist, and as a healthcare manager and consultant with experience in the District of Columbia. I'm particularly interested in the topic of behavioral health urgent care as one aspect of a system of care for crisis in the district. And as so many witnesses have already testified, it's all about community-based response and trauma-informed care. I applaud you having this joint roundtable as the nexus between police response and behavioral health crisis response deserves this level of careful attention. Behavioral health crisis response in the district is first a public health issue, and the initial response should be a trauma-informed response. I expect that most MPD officers would also prefer to have mental health professionals be the first responders in most behavioral health crises. The district has excellent resources that can bring people who are trained to respond to psychiatric emergencies as first responders. As the resolution states, federal partners at SAMHSA have championed crisis response nationally as including someone to talk to, someone to respond, and a place to go. I see behavioral health urgent care as a place to go. As you know, 1/5 of all Americans suffer from mental illness, and only half of them receive any treatment. Access to behavioral health is also complicated. So many individuals use the emergency department for their routine behavioral health care. ERs, however, are not a good place to receive high-quality care that is timely and appropriate. Wait times can be quite long. Often individuals are discharged without receiving meaningful care or with a warm handoff to their routine behavioral health care providers. Individuals who need either emergency or routine behavioral health services can be treated in a behavioral health urgent care center. This will decrease hospitalizations and the risk of institutionalization and ED visits, and it has been shown to improve follow-up care and increase both patient and staff satisfaction. I have previously discussed before the Committee on Health about the empath model for emergency behavioral health care. This model includes a freestanding unit that will treat children and adults and who do not have a history of dementia or other medical issues that would require a hospital level of care. The unit will be open 7 days a week with highly trained peer specialists who have lived experience playing a leading role in care and follow-up alongside mental health professionals and clinicians. There are two tracks within the Behavioral Health Care Urgent Care Center, one for the more urgent issues typical of crisis calls to 911 or 988, or more routine issues such as medication refills or case management back to the regular source of behavioral health care. The Department of Behavioral Health has had good success in opening their stabilization center, where many clients present with both mental health and substance use disorder diagnoses. Once these clients are stabilized on the substance abuse side, it would be a perfect time to connect and provide support to their behavioral health care needs, which are often intimately connected. I see trauma-informed behavioral health urgent care as a place to go that can support my neighbors in need of crisis behavioral health care. I urge you to consider this model as integral to a humane and trauma-informed response to behavioral health crisis. This is an issue that can and must be improved. Thank you for holding this roundtable.
Thank you. I don't see Kevin, but I do see Christy.
Good afternoon, Chairperson Henderson, Chairperson Pinto, and members of the committee. My name is Christy Blaylock. I'm the Vice President of Growth and Strategy for Cadencia and Regional Addiction Program, or RAP. I'm pleased to testify on behalf of RAP, which for more than 53 years has been an indispensable provider of substance use disorder treatment services to the district's most vulnerable residents. Today, RAP is the only district entity that provides a full continuum of ASAM SUD treatment services, including crisis stabilization, walk-in assessment referral services, withdrawal management, ASAM level 3.5, 3.1, and 3.1 residential treatment, and both intensive outpatient and traditional standard outpatient treatment services. As a safety net provider of SUD residential services, RAP would like to express its support for the Council's resolution and to share our perspective on the subject matter. We appreciate the Council's sincere efforts to strengthen the district's existing crisis stabilization infrastructure and crisis response system consistent with SAMHSA's recommendations. We acknowledge that these matters are complex and it will take time and patience and resources to improve them. As part of the committee's focus on creating a more coordinated and effective response to behavioral health crises throughout the district, we respectfully urge the committees to consider the district's broader behavioral health ecosystem. Simply put, many of the behavioral health crises, which are the focus of the Council's resolution, are largely avoidable. The affected individuals should be treated in community settings before their situations escalate into crises. Our collective failure to create and support existing community-based behavioral health options is contributing to this very crisis, which is the subject of the Council's resolution. Neither RAP nor any other safety net SUD residential provider in the district can succeed under the existing reimbursement rates, which undercut staff recruitment, staff retention, and overall programmatic capacity. As I testified today, every safety net SUD residential provider in the district is struggling financially. Indeed, we need to look no further than the shutting of 2 district residential SUD providers over the past recent years, both Safe Haven Outreach and Ministries and Salvation Army's Harbor Lights. The district cannot underinvest itself out of the historic crisis forever. The district's reimbursement rates for residential SUD providers have not been the subject of a rate study in over a decade, whilst costs have skyrocketed. Consider how RAP's residential SUD reimbursement rates in the district compare to the state of Maryland. Nearly 80% of RAP's residential SUD services are residential levels 3.1 and 3.5, which are reimbursed at rates 35% and 44% lower, respectively, than in the state of Maryland. Importantly, these ASAM services involving clinically managed high and low intensity residential services are essential parts of the continuum of care that is necessary for successful and sustained recovery. In the absence of these ASAM services, individuals find themselves in a vicious cycle of recovery, detox, relapse, recovery, detox, relapse. This cycle of rinse and repeat contributes significantly to the need for more intensive, more expensive, and less effective crisis interventions, as well as increased public safety involvement. As the district's largest SUD provider of residential services, we are working to transform our own internal systems to better serve our patients, and we acknowledge the need to do more. Still, no amount of internal improvement can overcome the math. It's important to note that over the past decade, Gaudenzia has invested approximately $15 million in direct investments and subsidies into RAP. This situation is completely unsustainable. The consequences of the underinvestment in SUD residential services are clear and devastating. According to the most recent data from the U.S. Center for Disease Control, opioid deaths remain the third leading cause of death in the district, behind only heart disease and cancer, but ahead of stroke, chronic lower respiratory disease, diabetes, homicide, Alzheimer's, and hypertension. If we are to address the issue of humane and trauma-informed responses to behavioral health crises in the district and to prioritize care over criminalization, reimbursement rates for SUD residential services must be appropriately set. The absence of these services is an invitation to crises. To that end, RAP is urging the Committee on Health to include the attached language within the fiscal year 2026 Budget Support Act, which would require the Department of Healthcare Finance to produce a report on residential rates by January 1, 2026. Chairpersons Henderson and Pinto, thank you for the opportunity to testify. We sincerely applaud your commitment to the subject matter and the hard work of you and your staff. We also extend our appreciation to your colleagues, as well as Mayor Bowser and her team for dedicated services to the district. Thank you for your time and for prioritizing this critical district issue. I'm happy to provide any additional information needed or answer any questions you may have.
Thank you. Shannon?
Good afternoon, members of the committees on Health and Judiciary and Public Safety and Council staff. My name is Shannon Walsh. I'm a Ward 8 resident, a licensed independent clinical social worker, and the clinical director of the Court Urgent Care Clinic. The Court Urgent Care Clinic is a partnership between DC Superior Court, the DC Department of Behavioral Health, and Pathways to Housing DC. The Court Urgent Care Clinic provides hundreds of adults with mental health and substance use challenges with same-day assessment and treatment. We support clients who have legal system involvement, co-occurring mental health and substance use disorders, and often have a history of trauma, homelessness, and incarceration. On staff, we have a psychiatrist, 2 mental health clinicians, a certified addictions counselor, and an intake coordinator. Our office is in a unique position to provide services to individuals regardless of if they have an ID, insurance, or residency status in the United States at no cost. We are conveniently located inside DC Superior Courthouse to primarily provide services to individuals involved in the court, but are able to see anyone in the district regardless of court involvement. Along with same-day assessment and treatment, the Court Urgent Care Clinic routinely evaluates clients who are in crisis. Coming to court is intimidating and stressful for many of our clients, which can lead to strong emotional reactions. In the last year, we have involuntarily hospitalized 10 people, meaning we must have involuntarily hospitalized 10 people. Meaning we must make the decision on the client's behalf to have them hospitalized due to their suicidal or homicidal statements or behaviors. That number is significantly lower than the clients who come into our office in crisis, because not everyone in crisis needs to be involuntarily hospitalized. Often the person just needs someone to listen to them. For example, we had a client who had never been involved in the legal system and had a panic attack in court. Her attorney and court security, though well-meaning, thought she may require involuntary hospitalization. As clinicians, we were able to identify her symptoms and develop an immediate plan for support. As a result, the person was able to calm down, which ultimately prevented police involvement and hospitalization. Unfortunately, when someone is in crisis and they are forced to interact with the police, their emotions are often heightened due to distrust of our policing system, and for many of our clients, this is a preventable re-traumatization. When people are having mental health crises, they need to speak with trained clinicians. The community response team does wonderful work, but they simply do not have the staff or resources to respond to the needs of the district. 2 weeks ago, a client reported suicidal ideation to me via text message. I immediately tried to call the client, but their number was no longer in service. I called the community response team, who encouraged me to call the police because their teams were already out in the community. This client was incarcerated for 30 years and had a strong distrust for the police, which gave me concern that I was putting my client and the officers in an unsafe position. Thankfully, with the help of the client's pretrial services officer, I was able to get in contact with the client and then at their request, stay on the phone with them while they spoke to the police. The situation was resolved without hospitalization through coordination between myself, the police, the community response team, and the client's core service agency. Involuntary hospitalization is sometimes necessary. The Court Urgent Care Clinic was called to a courtroom last year to evaluate a person having a mental health crisis. After meeting with the client, our team determined that they met criteria for involuntary hospitalization. The team called 911 and requested a mental health officer to transport the client. We sat with the client for an hour and a half before an officer responded to our location. During that hour and a half, we worked to keep the client distracted because they had voiced that they did not want to be hospitalized and wanted to go home. Once the officer arrived, the client was handcuffed behind his back and transported to CPEP in the back of a police vehicle. Although I understand the need to secure the person for their safety, there should be an alternative to police transport and handcuffing. Being handcuffed causes a preventable re-traumatization for many of our clients who have had negative experiences with police. This re-traumatization may prevent people from speaking up about their mental health concerns in the future. My call to the council and the mayor is to expand the community response team staff and resources, increase barrier-free mental health services like the Court Urgent Care Clinic, and find an alternative way to transport individuals to the hospital that does not require police or handcuffs. I thank you for conducting this hearing and am available to answer any questions you may have.
Thank you. And it looks like we've been joined by Chioma.
Yes, good afternoon, Chairperson Christina Henderson, Chairperson Brooke Pinto, and other honorable members of the DC City Council. I am Chioma Oru, the Health Equity Project Director at Advocates for Justice and Education, AJE. AJE is the federally designated Parent Training and Information Center, PTI, and the Family to Family Health Information Center for the District of Columbia. Each year, we assist hundreds of families through direct services, training, and advocacy in navigating the district's public education and healthcare systems, especially for children and youth with disabilities and special healthcare needs, including areas such as the special education process, school discipline, and behavioral supports. In 2021, AJE launched a health equity project to address health disparities in DC for Black and Latinx children and youth with disabilities and special healthcare needs living in wards 8, 7, 5, 4, and 1. Through the advancement of parent-led advocacy efforts in collaboration with health professionals and policy decision makers via an established community health advisory panel that meets bi-monthly. The Community Health Advisory Panel consists of veteran parents who are part of AJE's Community Health Ambassadors Program to develop peer health information leaders in partnership with an interdisciplinary body of healthcare professionals, including participants from the DC Department of Health and DC Department of Healthcare Finance, as well as healthcare providers working in the community, in community-based organizations and private practice. I appreciate the opportunity to testify on the proposed resolution, the sense of counsel in supporting humane and trauma-informed responses to behavioral health crises resolution of 2025. As an organization that advocates for family-centered practices and disability justice, we appreciate the council's recognition of the need to prioritize critical reform and urging of the mayor to establish compassionate, community-based responses to behavioral health crises while centering the needs and basic human rights of individuals with mental health disabilities and their families. Too often, individuals experiencing behavioral health crises, especially those with intellectual, developmental, or psychiatric disabilities, are met with punitive carceral responses that exacerbate trauma rather than provide the care and intervention they need. Families, caregivers, and community members witness firsthand the harm caused by law enforcement-led crisis interventions that fail to recognize the complexity of behavioral health conditions. While AJE continues to strive for functioning systems of care that provide more early and preventative treatment and services as the most critical needs to reduce health disparities for DC's disability communities, this resolution is an essential step towards shifting our city's approach to crisis care in ways that prioritize de-escalation, compassionate clinical interventions, peer support, and disability-informed care. A family-centered and disability justice lens requires that crisis response systems recognize the lived experiences of individuals with disabilities and their support networks. Families are often the first to respond to behavioral health crises and are in dire need of alternatives to calling the police, fearing that doing so may lead to escalation, injury, or incarceration. By investing in DC's capacity to implement SAMHSA's recommended approach to provide services that reflect the need of someone to talk to, someone to respond, and a place to go, the proposed resolution aligns with best practices that respect the autonomy, dignity, and self-determination of people with mental health disabilities, and truly anyone for any reason that experiences a mental health crisis. In conclusion, AJE recommends that the council and mayor work together to reshape our care delivery system and reduce healthcare disparities for DC's most vulnerable citizens. We look forward to continuing to partner in the systems of care work to make these critical improvements and welcome further collaboration by uplifting the voices, concerns, and solutions of impacted DC families. Thank you for the opportunity to testify today. I welcome any questions you may have.
Thank you. Thank you to this panel of witnesses. I want to ask Dr. Rob if you're still here, because I feel like you have probably the most direct experience as it relates to crisis response, specifically with minors, given the work that you all do at Children's National. What has been the feedback from your patients or their families who have come to you all by way of CHAMPS or MPD or another process?
I think that when people come from CHAMPS, a lot of times it's either from the community or from school because there's no family member there. If you're at home and you're in crisis, many times parents or other family members are able to get the child to come to the emergency room and receive help, which I think is always easier than having CHAMP or, for that matter, MPD. But sometimes people are in a real crisis and they're seriously mentally ill, or they're under the influence of substances, and they're not thinking logically. And then people like CHAMPs and MPD sometimes have to bring people in. I think the toughest cases are actually the kids with developmental disability. I remember a gentleman who testified in person who had a child with autism spectrum disorder or a developmental disability. I think those are the kids that have the toughest time, because their understanding of what's going on, their ability to communicate is more impaired than other people. And so they become frightened. And I think that's the toughest case of trying to bring somebody in for help. And that's where having additional training, and we've heard all kinds of important testimony today about what that might be or might entail. I think those are the kids and adults, for that matter, who have the toughest time when a security officer or a police officer or a CHAMPS member comes up to them to try and speak with them and get them to a safe place for an assessment. And it's just difficult. I think hearing from the parents and hearing from people with lived experience has really sort of helped the council understand how tough it can be, and how much in a time of budget cutback we really need all of this support, so that people don't escalate at home or at school or in the community or in church or elsewhere because we can't communicate with them.
Yeah. Thank you for being here. Shannon, if you're still with us, I want to express appreciation for your testimony. You gave, two very real examples of, in one instance, an individual who was at the courthouse who had a panic attack, and had it just been MPD or U.S. Marshals or otherwise, this person might have been involuntarily committed, even though that wasn't perhaps what was necessary in that moment. And so in some ways, at the Court Urgent Care Clinic, you all were the crisis response team for the courthouse. Is that a fair characterization?
Yeah, absolutely. I think that oftentimes we are called upon by the court, whether that be security officers who come and get us, or judges who come or who call us and say, hey, we're having this situation with somebody. Can you please come to the courtroom? Or even with pretrial and CSOSA officers, if they know that they have a client who's at a high acuity, they'll send them right over to our office.
Yeah. And how many staff do you have to deal with the entire court?
I believe it's 6 of us in total.
Okay. All right. Thank you to the rest of the witnesses. I don't have any remaining questions. Councilmember Pinto.
Thank you very much. And thank you to all of the panelists today. I don't have additional questions for this panel, but I do appreciate the conversation around the Court Urgent Care Clinic, and is something that we all need to be very vigilant about to ensure that funding is maintained year over year in this critical service, and to not have kind of mid-year dips. So I'll just say that that's certainly something on my mind, and I think it's going to take all of us being very conscientious about ensuring that that funding is maintained. And I appreciate all of the conversation around the kind of needed investment in this work. And I think a lot of that comes with staff capacity and training and re-education of the public in many ways of avenues that they have to call. But that has to be met with an investment from the city in building up this functionality as well, because we can't do one without the other, and I worry we won't move forward. So thank you all very much for being part of this discussion today and the work that many of you do in this space. And thank you to my colleague, Chairwoman Henderson, for your efforts here.
Thank you. All right. That was the conclusion for the public witness testimony. So regrettably, we learned yesterday afternoon that the executive branch will not be providing witness testimony today. We will follow up with the Department of Behavioral Health, the Office of Unified Communications, and the Metropolitan Police Department to gather information on their efforts to strengthen the district's behavioral health crisis response system. This does conclude our roundtable today for PR 25-108, the sense of the council on supporting humane and trauma-informed responses on behavioral health crisis resolution of 2025. And I want to thank all of the public witnesses who provided testimony. For anyone who was not able to attend and speak at today's hearing, we'll accept public witness testimony until Monday, April 14th at 5 p.m. You may submit written statements via the council's hearing management system website, dccouncil.gov/hearings. And this roundtable is adjourned. Thank you so much, Councilmember Pinto.
Cool.